Okay, so now let's summarize and use our whole system to understand the different problems that our 4 patients are having. So our first patient is Victor. And Victor is a 75-year-old man that has hand motion vision that he recognized today. And he woke up, was feeling fine, and then he lost vision in his left eye, painless visual loss. And when we test him, he has 20/20 vision and he has hand motion vision in his other eye. His visual field reflects that he has excellent vision in one eye, but hand motion vision in the other eye. He has a normal anterior segment pupillary and extraocular motility exam. His pressure is normal, but on his fundus examination, first I said, check the red reflex, and he will have a dull red reflex on one side and a normal red reflex on the other side. So let's summarize. This is Victor. He is a 75-year-old man. He has sudden painless visual loss with a visual field loss, but no relative afferent pupillary defect. He has a decreased red reflex with no view of his fundus. Victor has a vitreous hemorrhage. And this is what we'll see with elderly diabetic patients. Now, let's contrast this with another patient, and that is Craig. So Craig is also a 75-year-old man, and he has decreased vision as well. Now, if you really ask him, he's not sure whether the vision had been lost this day or not, but when his brother lost vision, he started checking his own eye and realized that, oh wait, I can't see out of this eye either. So this is discovered visual loss. And on the eye chart, he's 20/20 in one eye and he's 20/80 in the other eye. His visual fields are normal in each eye. His anterior segment examination at the slit lamp, he'll have a lens opacity in the left eye. He'll have no problems with his pupils, and his extraocular motility will be unaffected. His intraocular pressure is normal. With his fundus examination, you may be able to see his fundus, but more importantly, the red reflex may be dimmer on the side with the cataract, or you may see an opacity, which is the cataract in the red reflex that's blocking the vision. So in summary, Craig has decreased vision, a lens opacity, a change in the red reflex without an afferent pupillary defect, and Craig has a cataract. So more commonly, cataracts are something that patients will say that, yeah, I've had this visual loss for a long time. And for my example, I'm saying that he recognized it today. Now, let's compare that with their niece, who's a 35-year-old woman named Ophelia, who had visual loss in her left eye. She has 20/20 vision in the right eye and 20/80 vision in her left eye, just like Craig. Her visual field is normal. Her anterior segment examination is normal, but her pupil exam is not. She has a relative afferent pupillary defect with decreased color vision as well. If you challenge her with a red top drop and say, how much red do you see out of this eye compared to the other eye, she will say it's diminished out of that one eye. Her extraocular motility is normal, and I put a little asterisk here. Her intraocular pressure is normal, and her fundus examination most of the time is going to be normal, with a 33% chance that there may be some disc swelling. So I put a little asterisk here because she actually might have pain on eye movements. And for this patient, Ophelia, that has pain on eye movements, decreased vision, a relative afferent pupillary defect, and possibly disc swelling, this is optic neuritis. 70% of our patients with optic neuritis will be female, and the mean age is about 36. It's rare over 50. So most will have pain on eye movements, like 92% of patients, and most will recognize that the pain precedes the vision changes. Most patients also are able to remember the day that the vision change started, rather than being vague changes. They'll know it started on a certain day, and then usually the vision worsens from that time before it gets better. So that's optic neuritis. And then finally, we have Greg, is a 75-year-old man with visual loss as well. So his change in vision is severe visual loss that occurred in his left eye, and he has hand motion vision now when you test him. He has a decreased visual field on that side as well. His intersegment is normal. He has a relative afferent pupillary defect in the left eye, and he has no problems with his motility. His intraocular pressure is normal, and his fundus examination most of the time will show pale swelling of the optic nerve, although it's possible that you may not see pallor of the nerve or swelling of the nerve either. So this patient, Greg, has giant cell arteritis. So Greg has giant cell arteritis. He has a decrease in vision with an afferent pupillary defect that was sudden onset and severe visual loss in an elderly patient. You have to think of giant cell. And really, I should probably have used George, and Georgette would have been even better, because females are 2 to 6 times more likely to get giant cell arteritis than males. We should also, and the visual loss is profound in giant cell arteritis, or temporal arteritis is the same thing. It's usually count fingers, hand motion, light perception, or no light perception vision. We will be checking an ESR and CRP in these patients, which will be elevated. And we have to beware of a couple other patients as well. Let's beware of Amy and Donald. Amy is for amaurosis fugax. That is where you have 2 to 30 minutes of sudden visual loss, really usually your visual acuity, but it can be your visual field that then returns to normal. And an elderly patient that's had that happen to them once or even repeatedly this may be giant cell arteritis before they totally lose vision and go blind. And we also have to beware of Donald, and Donald is D for double vision, because elderly patients that complain of sudden onset of double vision may have this from giant cell arteritis as well. So again, they may be complaining about some other things such as fever, headache, and pain, and their pain may be facial pain, like scalp pain or jaw claudication, where the more they chew, the more they have pain. But I think the important thing to know about giant cell is that if you don't treat it properly, they can go blind in their other eye. And this is why it's an emergency when you see giant cell arteritis, and why you have to be so thoughtful about asking the questions. And what I really like to do on the eye exam is, when I think about the one thing they can't see that you can't see as the doctor is intraocular pressure, but the other thing you can't see is giant cell arteritis. So I want you to think about it in your elderly patients when they come in complaining of visual loss, or when they come in complaining of double vision. So that is my system of ophthalmology, which combines what patients' complaints mean about, how to structure your eye exam, and how to do your eye exam to help your patients. I hope you enjoyed it. And the answer to the question was no, I am not wearing pants. You're still here? The lecture's over. Go home. It's over. That's it.